Welcome, Dr. Eric Mitchell. It's such a pleasure to have you here. I know you're an orthopedic surgeon, and here we are. I heard your wonderful talk on the use of CBD for osteoporosis, a condition that I look for decades before it actually emerges as fractured hip or kyphosis in spine, where you get the curvature of the spine. And so I'm quite curious. We are at the 24th Clinical Applications for Age Management Medicine, and I'd love to learn more about your work in pain management and bringing the use of hemp and CBD, medical marijuana, to the people in America. How's that going?
Oh, it's going great, and thank you for allowing me to be here, and I've had a great time here. I've learned a lot, and hopefully I've given a lot. But let me first get all my disclosures out. Number one, I'm the medical director of a company called AGRiMed, which was the highest scoring of 12 medical cannabis growing companies in Pennsylvania. And I worked with a hospital administrator from 40 years ago. They came and got me because he knew that I was always a little bit ahead of the curve. And I said I would do this because I believe that we have to put this professional coat on this, because so much of this has been deleterious in the whole aspect of marijuana.
It's almost been political.
It's been vilified, and criminalized situation. But that I'm also the president and CEO of a company called Hemp Commodities Industry, because that's the long play. That's the long play, because medical cannabis, which I call it, and I ask people to call it medical cannabis and not use the Spanish word that they passed a bill in 1937 called the Marijuana Act. They spelled it with an H and not a J. And I try to get people to call medical cannabis, because medical cannabis has both two components, THC and CBD, which we'll talk about in a minute. And then thirdly, I am the medical director of Pine Tree Alternative Pain Clinic in Maine, where I live, where I see patients every week to give them and grant them what's known as a certificate. Because it's a schedule, because cannabis was ostracized and made a Schedule I drug in 1970 by President Nixon, then it says it has no medicinal purposes. And that's just, that's oxymoronic, because we have, the United States government has a patent on cannabis for its anti-inflammatory components, and we're going to talk a little bit about that.
There are receptors in the brain and in the body.
And all throughout the body.
Exactly.
All throughout the body.
There's an endocannabis...
it's the endocannabinoid system. And it's so funny because Dr. Raphael Mechoulam, from Israel, discovered the first, cannabinoid, the first cannabidiol, CBD, all the way back in 1964. And then anandamide came and was founded by the same institution, and then in 1992 the endocannabinoid system put it all together. Exactly. But it's not taught in medical school. There's not one medical board or state examination question on the endocannabinoid system, and that's just so.
I don't want to distract us, but I know it has to do with the fact that we were also growing cotton, and it had to do with the oils that came from hemp. So I think we should probably leave that out of it, because we want to focus on the positive use of it and how it could maybe avert this this opioid.
Well, I think that's really where we want to go, and that's why Hemp Commodities Industry is very excited, because we're going to have the largest production of hemp in the state of Maine, prior to the 1937.
And Maine has been a leader in the
Maine has been a leader in a couple of things, and that is trying to number one, we've had a 19-year history of having an alternative medical program, so that we allowed people to grow it. And then in 2006, the dispensary mechanism came in. And now I give certificates every week so that people that have cancer, that have a glaucoma, that have a number of celiac diseases, the gastrointestinal disorders, and what have you, and also getting people off of the opioids. I testified last year twice to Health and Human Services, trying to get them to add the opioid addiction to the list. We have 21 different maladies that we allow right now. And in some states, in addition to what we have, sickle cell, we don't have it in Maine. But this is a natural occurring botanical that has been around for anywhere from 12,000 to 7,000 to 12,000 years. And yet we tend to ostracize it, for different political reasons. But let's stick to the big pluses. The big pluses is I've gotten X number of patients off of their opioids.
By using
and diazepams. Specifically using cannabis. Mm-hmm. Because the margin of safety for cannabis is so large because we don't, number one, you have these what receptors called CB1 and CB2 receptors in the endocannabinoid system. And they basically, a large percentage of them are in the brain, but not in the brain stem. Because in the brainstem, when we have something like morphine or Oxycontin, it suppresses the respiratory components. And if you don't breathe, you die.
Right. So the dose that's effective is too high, and it leads to death in the opioid system, whereas in the cannabis system, a low effective dose would not cause respiratory depression.
That's right.
And so you're not going to cause any effective depression of the respiratory system. You don't die.
That's correct, because there are no CB1 or very few CB1 and CB2 receptors in the brainstem.
Right, exactly.
So what we have is no one has really ever really died of a medical cannabis situation. Now let's talk about the plant itself. The plant itself is called Cannabis Sativa. Okay, Cannabis Sativa is like the delicious apple, and then you have the Macintosh, same species. Okay, but they may taste different, they look different, and the likes. In the case of Cannabis Sativa, it looks the same, but one has THC, which is a psychogenic or euphoric component to it, where hemp has less than 0.3 THC, and that one has no euphoric effect. But it has, both of them have CBD, okay, which is the cannabidiol, which we call CBD. Now, what we've learned, Dr. Mashola, we talked about the first two, there are over 113 prior to coming into this room. Maybe leaving the room, there might be 120 because we are just opening it up to so much. But yet that's been around the world, because what we have a problem here in the United States of America, because it's been regulated by the DEA, it's very hard to get research done. I mean, the National Institute of Health, NIH, does a certain amount, and they've done some good studies, but it gets it out of all of the universities. I mean, I'm ready to reproduce a study right now on osteoporosis. Why? Well, osteoporosis is going to be a big futuristic problem for us because we have an aging population. And I think that, being here at the AMMG really points out all of the problematic situations with antioxidants and free radicals, and how the body needs certain nutrients and what have you. So I've learned, like I said, I'm taking on back home.
Osteoporosis alone, even 20 years ago, it's been predicted to be a $60 billion disease in the aging population, and that's direct costs. So if you look at indirect costs, when you fracture a hip, 50% of those individuals die almost immediately. And of the remainder, I think, who live, 50% of them can't live independently. Right. So not only are they affected, but their family members are affected, because either they have to be put in a home, in a nursing home, or somebody has to stop working to take care of them.
1 in 7 families, loses 4 to 5 vacation days a year in taking care of their family. Now,
or work days.
Work days.
And money.
And money. And they sacrifice their vacation and money and the like.
There's a government issue in terms of cost, and then there's a personal issue in terms of family and economics.
Absolutely. And what can we do to help to prevent that? Well, we're living longer. By 2030, they say the average life expectancy in the United States would be 90.3 years. In 1935, when Franklin Delano Roosevelt signed the Social Security Act, they set the retirement at 65. Why? Because the average life expectancy in 1935 of an American was 62 years. Okay.
But now it's closer to 80 or 80 something for us women.
That's right. And for you women, it's 80.
So
80
how does
plus.
does CBD have an effect on bone turnover, and can it protect bone as we age?
Yes. I attended the University of Pennsylvania School of Medicine, and I
only went to Yale.
Okay, that's okay. We'll forgive you. Okay. We went through electrically induced osteogenesis was my original research back then.
Fascinating.
And that was using the piezoelectric phenomena, showing how bone has an electrical potential, and we altered that electrical potential by virtue of adding an anodal charge to the bone of 20 microamps, and that's what I had to prove, that we could actually produce bone. And so we changed the membrane permeability. Now, what do we looked at it from a macro standpoint, and looking at from a microscopic standpoint, it's probably the difference between osteoblast and osteoclast. Osteoblast makes bone, osteoclast resorbs it. And now women in particular, postmenopausal, they tend to lose their estrogen, and which is another mechanism of regulation.
And testosterone has an effect on bone too.
Oh, absolutely. Okay.
So by about 70 to 80, 25% of men and women are at high risk of decreased bone and osteoporosis.
That's right.
Fractured hips, loss of spine density.
Fractured hips is a big one because it puts people in hospitals, but you're talking about the other millions of bone fractures of wrists, of ribs,
Holly's fractures of the wrist.
Collapsing of the vertebrae, and compression fractures in particular. And it's been postulated that in 20 years, 1/2 of the hospital beds in America could be filled with women with fractured hips.
You get compression of your chest cavity, can't breathe deeply.
Then you get also, foraminal encroachment. Okay, as an orthopedic surgeon, for years, for 22 of my 37 operative years, I did spinal surgery. And a lot of that was because of the compression of pain, compression of the spine, closing of the foramina, pressing on the nerves, pain down the legs, down the arm and the neck and the likes. So let's go back to CBD. Let's go back to the CB1 and CB2 receptors. And there's an agonist component that CB receptors are also in the bone.
So by using CBD, we have the hope of reversing or protecting the bone, growing bone cells, balancing it, and hopefully preventing the epidemic of osteoporosis we know is upon us. Decreasing the risk.
Decreasing the risk.
So research is needed. You're interested in making that happen.
I went back to the University of Pennsylvania where I did I have double fellowships from there, as well as my orthopedic, as well as medical schools and all of that. It took me 10 years. I tell people I wasn't very smart, so it took me 10 years.
But doesn't sound like that, but we're fascinated and we'd love to have you back here to tell us how this unfolds over the next year or two. Hear more about the research. Love to join you in those travels. I myself did research in osteoporosis as well.
Let's join together.
Definitely.
Right.
We're together, so we'll have you back to tell us how that goes, and maybe we'll be on stage together speaking about CBD and its role.
We will.
Thank you so much for joining us here at AMMG in Orlando, Florida.
Thank you so much.